This is our topic for today, NHS impact, embedding continuous improvement into healthcare. So in today's session, our ambitions are to, one, explore the principles of taking a strategic improvement approach and how that's developing a year on from the launch of NHS impact. Two, to understand the enablers and blockers in terms of improving health and care at scale. To think about the principles of quality improvement and how they can support any organisation in its strategic improvement approach. And finally, to consider what that means for us as leaders, and leaders in that wider sense across all of our organisations and systems. So thank you. We can move on. Our agenda for today is on screen. I may look like a mere slip of a girl. However, I've been working in improvement for close to 30 years. And it's a huge privilege to be with you here today. Absolutely wonderful to see so many people here, such a range of people, some familiar faces and some new faces, joining forces to put the energy, enthusiasm, expertise and experience behind this shared ambition of an improvement approach. We have three illustrious speakers today. If you are a member of what used to be called the Twitterati, but it's called X these days, you may have seen something about all of our speakers this morning on Twitter, as the team have been tweeting away, or the equivalent in today's forum, about our speakers. But let me tell you a little bit about them. So Erica Daley has joined us, and we're really grateful, Erica, because we know we had to do a bit of smart moving with diaries and things to make sure that we could get you here today. Erica is one of 6 place directors in the Humber and North Yorkshire ICB, and she specifically focuses on home. She started her career in nursing in learning disabilities and has held a range of senior clinical and managerial roles over the last 40 years or so. Sorry, Erica. Latterly, she has been focusing on commissioning integrated care services across Hull. And I know that she plays a very, very, very active role in working with and championing local charities, support groups and community organisations, as she calls them, the Hull champions. And their role is about championing a healthier Hull, supporting people in Hull to live healthier and happier lives. And she's going to tell us more about that today. We're also joined by Professor Sir Chris Ham, who is currently the co-chair of the NHS Assembly, an Emeritus Professor of Health Policy and Management at the University of Birmingham, Senior Visiting Fellow at the King's Fund, where he was previously the Chief Exec between 2010 and 2018, and then in 2019 to 2021, the Chair of Coventry and Warwickshire Integrated Care System. I'm sparing no blushes here. He was awarded a CBE for his services to the NHS in 2004 and a knighthood for services to health policy and management in 2018. He's a founding fellow of the Academy of Medical Sciences, a fellow of the Royal Society of Medicine, an honorary fellow of the Royal College of Physicians of London and the Royal College of General Practitioners, and became a companion of the Institute of Healthcare Management since 2006. So welcome, Chris. We're thrilled to have you here. And last but definitely not least, David Fillingham, CBE, currently chair of the NHS Improvement Board and Lancashire and South Cumbria NHS Foundation Trust. David joined the NHS in 1989, which was the same year as me, David, but there the similarities end in our career paths. And you joined after a career working in manufacturing. David has held several chief exec positions and is very familiar to many of us. He was director of the Modernisation Agency between 2001 and 2004, where his focus on developing new practices and fostering leadership development across the NHS contributed to his being recognised and awarded the CBE. In 2010, David was appointed as the National NHS Quality Champion, and Aqua is very proud to claim him as our chief exec until 2019, when he allegedly retired. But as we know, he's held a number of non-executive positions since then and has served as a senior visiting fellow at the King's Fund too. So we are thrilled to welcome all of you. We absolutely over the moon that you're able to join us today. In particular for sharing your thoughts, your insights, your experiences. In return, however, colleagues, our speakers would like to hear from you. They'd like to hear your comments, your thoughts, your questions. So This is the agenda. As you'll see, we've got a great opportunity for a panel question and answer session at the end. In the meantime, please capture your comments in the chat box. Keep them coming, keep your thoughts coming, keep any questions there, and we will bring them to that panel session. If I could ask you all to do two things. The first of them is to be really selfish. Take away as many ideas, as many insights, as many inspirations as you possibly can from today, and use them in your local practice. Take opportunities to connect with others during this session, people who work around you in your local system, and to work together. Think about things and inspirations you can take from today to maybe take some work forward in a different way that you wouldn't be able to do otherwise. And by the same token, the second thing that I'd ask you to do is to be very generous with your thoughts, your insights, your comments, your questions as we go through the session. And let's make this a really brilliant session for us all. On that note, what I'd like to do is hand us over directly to David. David is going to take us through the policy side, the national side, and his experience of chairing the NHS Improvement Board and all that that means. So, David, over to you, please. Thank you.
Thanks, Steph, and thank you for that really generous introduction. That was lovely. I want to start by congratulating the North West Collaborative on wonderful logistics, managing to plan this event for the very day that the Daley report comes out. So it's really timely, this particular session. It's great we've got so many attendees, and I'm particularly pleased that we've got a lot of colleagues from social care here as well. Those of you who may have heard Wes Streeton on the radio on the way in will know, and you'll also know from your own experience, that we face huge problems as a society and as a health and care system, and those are really complex problems, and no one institution, no one sector can solve those problems on their own. We really need whole system approaches with teams working together in partnerships, and I suspect that may be a theme that runs through today's session. I know Chris particularly and Erica will pick that up in more detail. We'll move on to the next slide, please. So I'm going to cover three things in my comments. The first is really a recap. I expect a lot of people who've signed up for this are already aware of NHS Impact, but a quick recap on what it is, why it's been set up, how it's working, and how it fits into this evolving national policy context. The second thing is to say a word or two about the progress that I believe we've made over the last year. Green shoots, a long way to go, but some really exciting developments. And then to be really clear and open about the challenges that we face. And frankly, I'm looking forward to today because I need your ideas and your input. And what I'm hoping is going to come out of the discussion are suggestions from you about challenges I may not have surfaced, but particularly about how we work together to tackle those challenges. So that's my plan. So I'm going to move through a very quick recap. And what I would also say is I've asked the team, I actually forgot to put on my slide, which I usually do, the link to the NHS England website and to NHS Impact specifically. So I know the Aqua team are going to pop that into the chat box along with my LSCFT email address. And I would really welcome any comments, questions you've got that you want to email me afterwards, and particularly examples of some of the great work that I know is underway, and as if by magic, Kath has just popped that link into the chat box. Thank you. Next slide, please. So I'm going to move through these next few slides quite quickly. And the first is just to explain that NHS Impact was born out of a review that was published in 2023, the Delivery and Continuous Improvement Review. And this came about really through reflections from the NHS England board, reflections that, as a system, we'd become a bit overly focused on performance management, on trying to get things done by asking people to do better and work harder, and a recognition that that was not going to solve our problems, and that what we really needed to do was have a much stronger focus on improvement, redesign, and transformation. And so the review was undertaken. Next slide, please. And the review was very clear that there is an extremely strong evidence base, which I think all of you will be aware of, actually in other sectors, in manufacturing and the service sector, and in healthcare internationally, not just in the UK, that those healthcare organisations that deliver the best outcomes for patients, that get the best use of resources, that move on to tackle health inequalities and improve health outcomes with communities, and who motivate and support the people who work in these systems, they all use a rigorous and robust approach to improvement. Not all the same one, but they do all have that at the heart about how they work. And next slide, please. The review concluded that we really need to do that in a systematic way across the NHS as a whole. We've got some fantastic examples of organisations and places using an improvement approach, but it's not widespread, it's not everywhere, and we need to accelerate and deepen that work. I just want to call out straight at this point the brand NHS Impact, because I've talked about a whole system approach. I didn't choose the brand. I think impact's a great word. I did a session recently with a lot of social care colleagues in the room, and there was a gentle but firm pushback around, is this just NHS centric? I think that's one of the challenges for us, and one that I'd welcome your views on in the chat box and when we get to the discussion at the end, because although this is branded as NHS Impact, we can't do what we need to deliver without forging those really strong partnerships across place and across ICSs. So what the Delivering Continuous Improvement Review recommended, and NHS England adopted these recommendations, is launch a single shared approach to improvement, not a single method, and I will come back to that in a minute. Create a National Improvement Board, which, as Steph said, I've got the great privilege of chairing, and really focus on leadership for improvement at every level. And I'm going to say a little bit about the progress that we've made on each of those. Next slide, please. So in terms of what do we mean by NHS Impact as a single approach, it's not about everybody using the IHI model for improvement or everybody using lean. It is about saying we want you to use a robust method. But the evidence is really strong that a culture of improvement has got these 5 things right at the heart of it. They're really the DNA of an improvement culture. So a shared purpose and vision, one that is aligned right through organisations and places and systems, that makes sense to people on the front lines, to people using our services, and that will motivate and inspire people to do more. Investing in people and in creating the right kind of culture. And by people, I don't just mean our colleagues, I mean people using our services as well. Developing the right kind of leadership behaviours, and all of you probably wouldn't be on this call unless you had some interest in improvement, and you will know that simply telling people to do it doesn't lead to an improvement culture. We need leaders who will coach and facilitate and support and inspire. And then, yes, develop an improvement method, whichever of those methods you choose to use. And I'm in favour, frankly, of a blended approach with a bit of everything that works locally and is owned at the place level. But investing in training, development, coaching and support to build that improvement capability and capacity. And then finally, this can't be a hobby. It can't be a nice to do on the edges. It's got to be at the heart of how we run our organisations, run our places and run our systems. And so we have to embed it in our management systems and processes, but we have to embed it in daily work. And those 5 fit together. I think they work just as well across places and systems. One of Steph said, I am allegedly semi-retired. It doesn't still feel too much like that. I think I was temperamentally unsuited to retirement, to be honest. And as well as those other roles, I have the great pleasure of working with Healthcare Wigan Partnership Board. I chaired that board for 6 years. I still do a couple of days a month with them as an advisor. And so we've been thinking a lot there about how this works at the place level. A shared purpose and vision that works across sectors, that's meaningful for colleagues working in local government, in BCSEF, that's meaningful for communities. Leadership behaviours that are about system leadership, not just institutional leadership. And as we build improvement capacity and capability and think about the tools and methods, that's not just the traditional, slightly manufacturing orientated improvement method in the hospital sector. It may be asset-based community development. It may be population health improvement approaches. We need a much fuller toolkit, a much bigger toolkit as improvers that we're working with when we work at the system level. Next slide, please. And the next slide, I think, just gives you a bit more depth on that, just to flag that that's there, and I'll repeat the sponsors advertisement that there is a lot more on the NHS England website in the NHS Impact bit that you can go and take a look at. Next slide, please. Just a word then on the National Improvement Board, which I'm delighted to chair. It's made up of some great people, CEOs, clinicians, improvement experts, some leaders from within NHS England as well. And we're building strong links and partnerships out. We have an input from primary care. We're building those stronger links with social care, voluntary sector. And I've just appointed, or in the process of appointing, two lived experience colleagues who are going to be members of that board as well. And over the last year, we've now been in place for 12 months, and addressing three things. The first is a series of short-term practices that you can see here, which are really been part of the launch year, the launch phase of NHS Impact, getting the message out there, letting everybody know what this is about, inspiring and encouraging people to take part, and working across a whole network of support partners and agencies, from the Q community, the Improvement Directors Network, the Healthcare Financial Management Association, the Royal Colleges, ADAS, a really broad church who was seeking to get engaged. And that last point is interesting because we all know that improvement cultures really work best when they are role modelled by our senior leaders, when there's that support all the way down through the organisation. And I'm very pleased that NHS England have recognised that and are on their own improvement journey. So we've had a development session with the NHS England Executive Board. They've appointed an improvement team. They're developing a whole suite of training programmes for their staff and a set of improvement projects. They recognise they're absolutely at the start of their improvement journey, but it's really good that they are on that improvement journey. Next slide, please. And then the final thing that we've been doing is thinking about our longer term vision and aims and shaping a multi-year plan to deliver on that vision. And the National Improvement Board have adopted the quadruple aim as the framework for our aims. I've happened to share here a Lancashire and South Cymru Foundation Trust slide, which I'm the chair of. We thought of it first. In fact, this is a framework I've been working with since the mid-1990s, and I find it really resonates with frontline colleagues. I had a great visit to our specialist dental team in Ringway Medical Centre in Preston recently, and they played back to me their work under the same headings of the quadruple aim, how we improving dental health for children in Preston, particularly from the most deprived wards in that community. What does best possible care look like? Is it safe and effective? It's not being timely, but the access times are really improving. Is it equitable? Do people from different backgrounds and different needs get the same care? And is it giving the right kind of patient-centered experience? And are we efficient? There was a lot this morning on the radio about productivity and the need to improve productivity, and you will all be very much aware of the terrible financial constraints and challenges facing the NHS and local government. And we are stewards of taxpayers' money. We have an obligation to get the best value from that taxpayers' money that we can. And finally, unless we can create joy and pride in work for our colleagues, make it a great place to work, enthuse and inspire them to get engaged with improvement, it's never going to happen. So those four long-term aims are how we're going to measure the success of NHS Impact. Next slide, please. Our longer-term goal is that in 5 years' time, the NHS should have become the fastest improving healthcare system in the world. Not necessarily at that point the best, with the best outcomes, but the best at doing improvements. That's our commitment, and we will measure that through are we beginning to see tangible improvements in all aspects of that quadruple aim at the organisation level, critically at the place level, at the ICS level, and nationally. And we've identified three big drivers to help us deliver that. And I'm going to use these to also describe a bit of the progress that I believe we've made in the last 12 months. I mean, the first is delivering results through improvement. I'm going to mention in a minute some big national programmes that are just about to be launched now that the Daley review has been published. But even more important, the work already underway in the NHS. I love my colleagues in NHS England to bits, but there's a little bit where they think the NHS doesn't do anything until NHS England tells them to do it. And that's not my experience. colleagues in the NHS, in social care, in local government are passionate about making services better, tackling inequalities for our communities. There is a huge amount of good work going on out there, but it's often in little pockets. We're not very good at servicing that and getting that spread everywhere. I'll come on to that because that's our third and final driver in a minute. But I think as well as this local work, we do also need some big national programmes. And the National Improvement Board has set 4 big priority areas for this year. You won't be surprised by any of them. Primary care, maternity services, elective flow for people needing assessment and diagnosis and treatment, and emergency flow. And that is for me the biggest. You know, when did we allow something called corridor care to become a thing? We are not serving our patients well. And we know that that's having a huge effect on staff morale and on productivity too. So NHS Impact is about to launch a support programme on elective flow and emergency flow, a series of data toolkits, improvement guides and learning and improvement networks in every region to support trusts to learn from the best practice, to reflect on their own position and to work together to improve. Initially, that's focused mainly on in-hospital pathways, and I recognise that's only 50% of the solution at the best. I do think there is huge scope to reduce unwarranted variation in those pathways, but we are already working on gathering the evidence about what's working out in those systems, those places who are adopting whole system approaches. I know Chris and Erica are going to talk more about that. And we're looking for a phase 2 next year that begins to develop improvement guides and learning collaboratives around those whole system improvement approaches. So really, NHS Impact Year 1, identifying some of those great examples of local results for improvement, but we're beginning to develop some big national support programmes too. Secondly, developing leadership for improvement. And, you know, we already have a fantastic suite of leadership. This is co-sponsored by the Leadership Academy, so another plug for our sponsors. Some great set of leadership programmes. I was out on a visit to our Blackburn wards the other day, met a colleagues on the Mary Seacole programme, full of enthusiasm for that particular programme. We need to make sure improvement is embedded in all the leadership that we deliver. But we are also particularly looking at 2 new interventions, a very exciting potential development programme for clinical and operational leaders in the NHS, which I hope will have resonance for colleagues working in social care and local government as well. For those colleagues who work in the NHS, I'm really thinking about Band 6, Band 7, Band 8 clinical and operational leaders, really giving them some systematic development in those things that we know are really help operational effectiveness, the right kind of improvement tools, as well as some development themselves as leaders. And we've been working with the Proud to be Ops movement to develop that and have funding to take it further and to roll it out in 25-26. And then finally, a commitment to develop support for boards and for executive leaders. And we're working very much with the Workforce Training and Education Directorate, Navina Evans and her team in NHS England on that. And we'll be working with the Leadership Academy. Again, something that's one of our ambitions for 2025-26. And then finally, I've already flagged this, creating the conditions for much more rapid and effective spread and adoption. There's almost a sense in that if you look across the NHS, somebody somewhere has got a solution to nearly every one of our problems, but we don't spread that even within a single trust, let alone across a place or a system or the NHS as a whole. So we're developing our approach to spread and adoption, a really strong evidence base, clinical leadership, bringing people together in peer-to-peer learning networks, using a robust improvement method, and really aligning incentives, financial, reputational, and altruistic incentives to get the things that we know really work to spread alongside fostering innovation to develop new solutions too. Next slide, please. So just wrap up this section by summarising what those long-term goals are, and then I'm going to come on and talk briefly about the challenges before I wrap up. So in 5 years' time, we're going to be looking for demonstrable improvements across all those quadruple aim measures right throughout the system, at neighbourhood level, provider, place, ICS, and the national level. And my ambition would be that every provider and place in ICS will have their own culture and system for improvement. I don't think that, I don't mind whether that's got the NHS Impact brand tag to it or not. Frankly, it should be something that works in Blackburn or Basingstoke or Bournemouth and makes sense for that for those people locally. And that those should have moved out beyond the NHS, that we've got wide-ranging partnership work on improvement and genuinely whole system solutions across place. And that needs to be both the small steps of continuous improvement, but also much more radical transformation. So it might be how to make outpatient departments work more effectively, but it might also be, do we really need an outpatient department at all? Or are we going to do something really radical, decentralising it, moving out into the community, using new technology, really moving forward shared decision making with patients at scale? And at the heart of that, I mean, some of you may have read the new local paper on a community powered NHS. It's a paper I'm a great fan of. This needs to be powered by local people and by communities and people with lived experience right at the heart of it. And it's only, I think, if we do each of those things, then we can say the NHS will then be regarded, I would say once again, because I think in the 2000s we were regarded internationally as a leader in continuous learning and improvement in health and social care, and that's something we need to get back to. So next slide, please. So all that hopefully sounds positive, but I'm very, very, very well aware. I chair an NHS trust that's responsible for mental health, learning disability, autism services right across Lancashire and South Cumbria. Believe you me, I well understand the massive challenges we have, from the pent-up demand, the stresses and strains on staff, the huge financial challenges. So we need to respond to these challenges of implementation. So some of that is about getting our leadership style right, and we cannot performance manage an improvement culture onto the NHS, onto players' partnerships. We can't just tell people to do it. We've got to inspire, not instruct. And yet I recognise that sometimes I think we lapse back because the short-term pressures into that more traditional performance management style. So a challenge is, how over time do we shift that leadership style into more of an improvement one? This can't be just about delivering programmes. I do think the national programmes I've described are important. I think they will add value, but it isn't really just about that. It's about engaging all 1.6 million people who work across the NHS and the many, many more people who work in social care, the voluntary, community, social enterprise and faith sectors. We need to build a social movement that is going to make this happen. We need a permissive approach. Again, there is always a temptation, I'm afraid, when you label something as a national approach, that it's got to be, everybody's got to do it the same way. I don't mind what approaches are taken locally. I would like to see them branded as a local approach. But those 5 pillars of the DNA of an improvement culture are really important, and we should be looking to see if they're there at every opportunity. Again, on our website, there's a self-assessment tool, a self-assessment framework that colleagues can use to see how you're doing and where you need to make improvements. And so in my own trust, we've used that, and I've got a development plan linked to it. We need to develop that improvement leadership style at every level, and we particularly need to nurture skilled system leaders. I'm a big fan of the Leading for System Change programme that the Leadership Academy have developed. We need to align that with our improvement work. And finally, we need to, improvement, as I said already, can't just be a hobby. It's got to be right at the centre of how we're trying to change and transform the NHS and social care. And it needs, therefore, to align with all the things. It needs to align with the performance management regime, with policy innovation, a lot of which I think we'll see in the development of NHS Plan Mark II over the next 10 years, and with the wider financial framework. But we should always be advocating within all of that for the power of an improvement approach. It's not just about performance management and money and incentives and policy. It is about those things, but with improvement principles at the heart of what we're doing. Next slide, please. And I'm almost done. So just a final summary of some of these challenges, framed, I think, in a way in which I'm inviting you to give me some of the answers, not ask me and Chris and Erica questions about them. So clearly, we've got huge short-term pressure, whether that's waiting times, staffing issues, money. How do we balance the wish to get results at real pace in year this year against the recognition this is a long-term cultural transformation. I think this is a 5 to 10 year transformation of how the NHS, social care and place partnerships work. How do we get pace whilst making sure that particularly very senior colleagues recognise this will take time, and we have to give these green shoots the time to grow and to flourish. How can we adapt NHS impact so it's not just NHS impact? It works across sectors. How can we adapt it to tackle whole system problems? I gave some indicators of my early thoughts on that, so it adds value for everybody, for all partners in place. And then the third one is I think possibly the biggest, with all the day-to-day pressures everybody has got. How do we create the time and the headspace for leaders and colleagues at every level to focus time and effort on this? Because there's that catch-22 of we are so busy that we can't get involved in this improvement work. And yet, if we don't get involved in the improvement work, we will forever be so busy, and we've got to break through that cycle. And then finally, there's a lot of initiatives that come out that sound okay at the beginning, and then you get an audit checklist and some more forms to fill in, and it suddenly gets embedded in the CQC framework. It kind of takes the fun out of it. And actually, what should be more inspiring than working with teams to improve the quality of care, to improve health outcomes in our communities, to tackle inequality? It should be one of the most inspiring and fulfilling things that we can do in a career. And we need to keep that focus. So final slide, please. That's a very quick canter through what Impact's all about, the progress I believe we've made, but the big challenges we still face. And I'm really keen to hear your reflections when we get to the discussion, your experience of NHS Impact today, if you've had it, and particularly how do we work together to tackle the challenges we face. I'm particularly interested in some local examples of success too. And as I've said, please do send those in, because I will forward them onto the national team. We'll do our best to promote them and to spread them. So thank you. I believe I'm now handing back to Steph, who's going to hand over to Chris.
Thank you, David. Wonderful as always, and some real challenges in there. I'm quickly flicking through the chat box, and there are some great comments in there that we'll bring through to the panel discussion later on. So if you want to keep an eye on those too, our panel members, it's some fantastic stuff coming through, and some challenges as well, actually, some really good questions. Conscious that David, you mentioned a couple of things about the ambition here is about the NHS being and care, the health and care service being the best at doing improvement. You talked about that critically at neighbourhood, place and ICS level, and a driver of that being creating conditions for spread and adoption and a social movement. Which is a wonderful, wonderful segue to Professor Sir Chris Ham, who has been doing some work in looking at case studies of where this is happening at system level, what's working, what the levers are, what the changes are, what the barriers are, and what needs to be in place. So, Chris, if I could hand over to you to carry on the narrative, that would be wonderful. Thank you.
Well, thank you very much, Steph, and thanks for asking me to contribute today, following on from David. Dave and I have been colleagues for longer than we both care to remember, so I'm going to reinforce some of his points and then bring in some of the evidence from this report, which was published by the NHS Confederation, Health Foundation and the Q community in November 2023. As you can see, it's about improving health and care at scale and looking at improvement through the lens of the integrated care systems in England. What are they doing and how are they adding to the history we have over at least 20 years of taking improvement work seriously? So I'm going to spend my 15-20 minutes or so giving you a summary. There's a lot more detail you can find in the report itself. It's freely available to read online or to download from the Confed and from the Health Foundation. So really emphasizing the scale of the challenge we're faced with in relation to what David has set out in particular on NHS impact. Improving health and care at the scale of a population such as England's, I think it's almost 60 million people now, has never been done before. We've tried, haven't we, through the MOD agency and successor bodies to do some of that work with some success, but also real challenges. And we've learned there has to be realism about how long this will take, and the need to be constant in our purpose. That's a phrase from Deming, whom many of you will know. Have that constancy of purpose, to stick with the plan, to be adaptable, of course, as the plan is implemented, to learn from what doesn't work. And we need national leaders who will show more constancy and consistency, I would say, than has often been the case when it comes to change in the NHS. And I'd pick up on the point about the Darcy report and the timeliness, Seth, of today's discussion, because if you listen to everything that Keir Starmer and Wes Streeting have said, they're not promising to put shed loads of more money into the NHS. Their argument is that we need to use what we've got much better. We need to focus on reform rather than so much on investment. And what you might say is actually improvement is what reform needs to be about, which is why I'm very much supportive of NHS Impact, the work of the Improvement Board, and the work I will now go on to describe. And this report is based on field work, which I was asked to conduct during 2023, leading up to the publication last November, based on the work of a number of integrated care systems. Subsequently, more recently, I was asked to do some work in North East Yorkshire region to look at what the 4 systems there, including the one that Erica works in, have been doing to work with the region and with their partner providers and local authorities. So I'll reflect a little bit on that in addition to what you will find in this report, but the North Eastern Yorkshire work has not yet been published. So if I can go on to my next slide, please. This is a map of the country, and you'll see from the flags, I worked with these systems as case studies to really make this a very grounded and empirical piece of work, interviewing a variety of leaders from the NHS, from local government, from the voluntary sector and elsewhere, to ask for their views on what was happening and what are the learnings coming out from that. So 8 case studies covering actually in practice 10 different systems. They were chosen because they had moved from thinking about and planning improvement at scale to doing improvement at scale. So I really wanted to draw on the actual experience of trying to do that work, not just the plans and the thinking. And you might ask, how did I come about choosing these systems? Good question. They were chosen based on my knowledge. I've worked closely with integrated care systems over several years now, but I also took advice from people who are much more involved in the improvement world, in the Q community, in the Health Foundation, and indeed in the NHS Confederation. And I could have looked at more or different ones, but this seemed to be a reasonable sample to select for the purpose of understanding, in the early days of ICSs as statutory bodies, what experience they have to offer, and what did that experience tell us about the ambition to do this work much more at scale. So if I can have my next slide, please. The good news here is that I found innovation and improvement was very much alive and well. The systems that I worked with, they built on the legacies they inherited. You don't need me to say this, but they weren't starting with a blank sheet of paper. In every system, there were legacies that were helpful in most cases in terms of the experience that provider trusts and other partners brought to the table on doing improvement work, investing in training and development of their staff, working with international partners, in some cases like Virginia Mason or Canterbury Health Board in New Zealand. And what the systems had done almost universally, the names, the language may vary a little, they were developing what they called learning and improvement communities, our virtual communities, trying to connect people with expertise, such as those in the Q community, within the boundaries of the integrated care systems. And they weren't trying to impose a new model. They very much emphasized going with the grain of what already existed and recognizing actually it was okay if there were different methods and different approaches and different philosophies of improvement, they could coexist, because it was more important to have that motivation, that ownership at a local level. And rather echoing here what David was saying about the national approach, the focus was in each system on identifying what are the common principles of improvement, rather than using any particular method. They described themselves, those involved in leading this work, as facilitators, enablers. They weren't instructing people what to do, leaders and staff in partner organizations. They were seeing themselves as adding value by creating these virtual communities, by making connections, by supporting the application of improvement expertise to parts of the health and care system that hadn't really benefited from that in the past, because they may not have had the resources or the understanding of the best way of doing so. So it's about spreading improvement expertise, sharing it, and achieving more impact as a result. My next slide. What's interesting here, and again, I'm going to echo in part what David said already, many systems had set ambitious goals, not just for improving health and care, but for improving population health and well-being. Dorset would be a good example, but each of the systems had very ambitious goals for improving the health of the population, increasing healthy life expectancy, for example, reducing inequalities or disparities in health outcomes in the population, reducing suicides in younger people, many other examples, and they're all in the report if you want to check what they are. Secondly, they were using data, and we're awash with data, aren't we? But we don't often use it very effectively to understand what's the need in our population and what's the demand in the population. How do we then use that to develop actionable insights on improvement? They weren't trying to take on functions better done by others. They were adding value by working with and through others in the way I've been describing, as facilitators, as enablers, and trying to identify, so are there some issues which are best led across the system and others which are better led at a more local level, or indeed within individual organizations? If I can move on to the next slide, I'm going to give you two examples here. First one is up in the Northeast and North Cumbria. Sam Allen is the Chief Executive of the Integrated Care Board in Northeast and North Cumbria. One of the biggest, if not the biggest system in the country in terms of its geography, large population, very much dispersed across different parts of the country. And what Sam and colleagues said to me is that in Northeast and North Cumbria, generally, delivery of care has been assessed as being good, if not very good, by the Care Quality Commission and by others. But in that region, in that system, health outcomes are actually variable and often rather poor, reflecting the makeup of the population, reflecting deprivation and poverty, unemployment, the history of often old industrial areas, which are making the transition to a newer future, and wide inequalities, of course, as well. So they said early on, one of the ways which we can add value to what's already going on is to focus on how do we improve health in our population. And it can't just be about making care even better, because it's already pretty good in most of our providers. What we've got to do is create partnerships. NHS working hand in hand with local authorities, with the voluntary community sector, with the education sector, sometimes with the private sector. Only if there is that wider collaboration through those broadly based partnerships where we really see the results we want. And I'm not going to go through this slide in detail, it is in my report, but it's about creating a learning community, a community which is committed to sharing information, where organizations are willing to be good partners to support each other. And another example would be around ambulance response times, ambulance waiting times outside emergency departments, where Sam and Annie Laverty and colleagues described to me how they were facilitating a pairing up of different providers and different systems within the North East and North Cumbria, different places, to learn from each other and to support each other, so that those who were doing well were generous in their time and their expertise to support their colleagues who weren't as far ahead. The other point I'd make about North East and North Cumbria, and Sam personally is very committed to this, is that people with lived experience play a very prominent role in their work. A lot of their meetings and their community events are fronted by people with lived experience as a very visible reminder what this work is all about. It's easy to get stuck in a kind of technical debate, isn't it? Unless we keep on coming back to who we're trying to improve for and what matters to them, and listening to what matters to people is very central to the North East and North Cumbria experience. I have my next slide. The second example is the system that, David, you're working in Lancashire and South Cumbria. There's a lot I could say about this, but you're much closer to it than I am. In this system, Ailsa Brotherton and colleagues are very much leading the work. It's a financially challenged system, a complex system with different places and geographies, each with their own identities. The example I want to give here is rather different from what I've just been describing in North East and North Cumbria. It's the work led by Andy Knox, one of the lead GPs in that system. He's also Associate Medical Director for the Integrated Care Board, and he is working with other primary care network directors and leaders on improving population health, tackling inequalities in outcomes at a PCN, at a neighbourhood level. And this rather busy slide, again, it's in the report for you to look at if it's of interest, is really about the methods they're using to increase their capabilities, their leadership capabilities, as well as their improvement capabilities, supporting the PCN directors and leaders to do what's appropriate in each of the different neighbourhoods in Lancashire and South Cumbria. They've created a population health academy, and that academy sort of in-house for that system is playing a major part in capability building, supporting that leadership development. And in each system, they're placing the emphasis on listening to people and listening to local communities, recognizing that each community is different from the others. Unless you go out with an open mind and hear what people say matters to them, then the risk is you put in place interventions which are missing the point in relation to improving health and tackling health inequalities. So very much locally led, GP-led, and GP-led on the principle of building partnerships at the neighbourhood level, local government, voluntary sector, communities. This is the people-powered, community-powered idea that David alluded to. If I move to my next slide. So moving beyond these two examples, what I would say about how improvement is happening is providers, and I'm talking here about NHS trusts as well as other providers, obviously continue to deliver most care, and some have really well developed QI capabilities which have been put in place over several years. I came across examples of that. But secondly, and we'll hear from Erica about her work in Hull, which she shared with me in the work I've done more recently in North Eastern Yorkshire region, the importance of place and place partnerships. Most systems are working on the basis of devolution and subsidiarity, and places are very important in that. I've given the example from my report about how that works in Wakefield, where Joe Webster is the place leader doing fantastic work of this kind. Erica will talk about the work in Hull, but it's about recognizing places. This is really what matters to many local authorities, voluntary community sector, how you can bring all the assets together in terms of the issues around care delivery as well as population health. Provider collaboratives are significant. I've given the example of West Yorkshire and the Alliance of Acute Hospital Trusts, which has been going now for 7 or 8 years, when Julian Hartley and Rob Webster brought together the trusts, 5 acute trusts now in West Yorkshire, who collaborate on many issues to do with the elective recovery programme, looking at opportunities to reconfigure clinical services, and they've done that in some challenging, difficult areas because of the trust that's built up within the acute hospital trust community, and recognition that there are some services which are better centralized and others which are fragile. Smaller specialties cannot be provided in every hospital, and therefore working together makes an awful lot of sense. And then the last point here is that systems aren't hermetically sealed. Give the example of Addenbrooke's Cambridge University Hospitals in Cambridge. In the east of England, it's involved in work across the whole of that region and beyond, because it has some very specialized services, and it makes sense there to work with colleagues in Norfolk, in Suffolk, in other parts of the east of England, as well as being a good partner within the Cambridge and Peterborough integrated care system. So it's a kaleidoscope here. That's the kind of picture I'm trying to convey. That's the metaphor that occurs to me of improvement happening in many different places, but in a way being orchestrated or coordinated, enabled by integrated care systems and their leaders. Next slide. So what about the next steps? I've got a few more things to say, and then I'll draw to the close of my time. There's really good work north of the border. Health Improvement Scotland has been working for over a decade on many of these issues across a population up there of about 5 million. And I had some very stimulating conversations with the people who've been leading that work. In local government in England, there's a tradition of sector-led improvement, of local authorities supporting each other and learning from each other. And confusingly, in social care, there's something called Impact, led by my former colleague at Birmingham University, John Glasby, which is about how you achieve social care improvement. And a number of universities are active partners in that, as well as the University of Birmingham. And of course, there's a typo here. It should say international exemplars have been very important partners in some of the systems. So Sam Allen, North East North Cumbria, drawing on colleagues in Sweden and in the United States. Let's be honest about this. Not every integrated care system is as far ahead as some of the ones I've been talking about. We need to value peer-to-peer learning and peer-to-peer support within the integrated care system family, rather in the way that sector-led improvement works in local government. System leaders said to me, because they'd been working on these issues before NHS Impact was announced, they really want to have room to work on the local priorities they've already identified. And they very much hope that the national approach will focus on a small number of priorities that matter across the country as a whole. And they really want to make sure they have time and space to work on population health improvement, not just core NHS priorities. They're both important, don't get me wrong. What I would say is the work on population health improvement is less well understood and less well described than work on healthcare improvement, where there is a long legacy and much has been written about how best to do that and the methods that should be employed. I liken work on population health improvement to what I would call community development. Showing my age here, community development was very much in fashion 30, 40 years ago, particularly in local government. And it requires, I think, a different toolbox than the one we perhaps used to around improving care delivery. And the last point is aiming for a high trust, low bureaucracy approach to improvement, not a one-size-fits-all approach that stifles local innovation. My final slide, please. I want to acknowledge the support I had from these organizations in doing the work. They continue to collaborate and take it forward. They are themselves supporting networking and shared learning across different systems. In fact, I met a colleague from Lancashire and South Cumbria yesterday who talked about the linkage between that system, colleagues in the Northeast and colleagues in Scotland, facilitated and enabled by the Health Foundation and the Q community. And just to name check Penny Pereira and Matthew Taylor, who I work closely with in doing this work. So Steph, that's enough from me. Can I pass back to you?
Chris, inspirational and insightful as always. There is so much to take away from that. I particularly liked what you said about population health improvement versus healthcare improvement, and the need for both and. We're hearing a lot in the media, particularly given the publication of the Daley report today, about today's high profile priorities, but what you articulated and what you've seen in systems around creating healthier populations through collaboration and partnerships is a really, really powerful message. And it is about not waiting for NHS England to tell us to work on something in particular. It's work on the things that are important to us as well. And that is a beautiful, beautiful link to Erica. So Erica, if I may invite you to tell us about your experience and your work in Hull, that'd be wonderful. Thank you.
Thank you, Steph, and thank you for the opportunity to share some of the work. I'm presenting this on behalf of our Discharge Collaborative in Hull, and hopefully we'll be able to share the example of just what Chris described, actually removing some of the bureaucracy to create the conditions for innovation. So first slide, please. Can move on to the next one. So just to give you a little bit of background and context, if you're not familiar with our area. So Hull is one of the 6 places that sits within the Humber and North Yorkshire ICS. We're one of the largest population ICSs in the country, and made up of our 6 places who are all aligned with our local authorities. Within that, we have 4 large acute hospital sites, just over, I think we have about 42 primary care networks, mental health trusts, community interest companies, and really importantly, and what I'll talk about as we go through the slides, thousands of community and voluntary sector organisations that we have created as one of our collaboratives, which I think were quite unique as an ICB in creating a collaborative of the BCS community. So that's our ICS. And next slide, please. That gives us a little bit of context about Hull. So as I said, we're one of the 6 places that sits within that larger geography. We're very much focused on population health and reducing health inequalities. Hull is the 4th most deprived population in local authority population in the country, and we do have the highest levels of deprivation in the city within our ICS footprint. So strengthening integration, working across health and care partnerships and community partnerships has always been at the core of what we try to do in the city. And that really is about trying to reduce variation, achieve better outcomes through best practice. Whilst we have a population of younger people in the city, it's actually our over 55s who create the pressure that we find across our health and care system for services and for support. We do try to intervene in terms of early intervention and prevention, but we're always working with that important and urgent dynamic around, placing our time and resources where we can in the upstream work and the prevention work. We've had some real success in frailty services, but we also have the pressure that I think most of us across the system experience, particularly around our acute hospital, in terms of pressure for people who have long-term conditions, comorbidities, and people tend to present in Hull with frailty-type conditions at a much younger age. So lots of our work is concentrated on trying to manage that dynamic and get ahead of the curve in terms of some of our work on health inequalities. Next slide, please. So I've picked this example. We did speak to Chris about it earlier in the year as one of the case studies that he was looking at. Hospital discharge, I think most people on this call will be familiar with the issues that presents to local systems and to, most importantly, to our patients and their carers. We have a history, I think, within Hull of always taking a very acute hospital approach to the problem. So we get our heads together as leaders in health and care in the acute and community sector and with the local authority, and try and understand the data, put different work streams in, try and reduce the steps we had to improve patient flow. We had a real pressure, particularly last year, on social care and some local challenges in terms of the care market and the fragility of that. We do have an issue sometimes with workforce because of the geography of the city. We were also, and I think this again is a national trend, that we were seeing a higher acuity of admissions and hence more complex discharges. And I think it's fair to say, and my local authority colleagues would concur, that they weren't quite ready for that extra complexity. So all that was impacting on us, and we were a real outlier in terms of our delays for transfer of care, or the no criteria to reside pathways as they're described. We were also seeing a higher rate of reattends in our older and frailer population, which created that sort of cycle that's described there. So that was our local system problem that we knew we needed to have a different approach to and do something different to get some different outcomes. Next slide, please. So the thing that we did differently was that we'd always worked really closely with our local voluntary and community sector around discharge pathways, and we had a couple of organisations who were already commissioned to take some transfers of care, follow people up with calls once they got home. But they were sort of at the end of the pathway, and if I'm honest, at the time a little bit of an afterthought. So we were very focused on what we could do as health and local authority, and it was seen as a little bit of an add-on. And we realised that that was a huge mistake, and we were keeping resources and people who knew our population on the periphery of a problem, and actually we should be bringing them in. So what we did, which we hadn't done before either, was that we brought together, we put out an invitation to organisations in the city, not just the ones that we already worked with, but a wider group of people who you wouldn't always necessarily associate with providing transfer of care and support at discharge, but were working in the city and knew our populations. And we shared some of the data that we used on a daily basis to try and manage our patient flow. So we shared things on length of stay, we shared things on where our particular process issues caused a problem. We explained the work that we tried to do in terms of more complex discharges on pathways 1 to 3. And we explained the issue that we had as a local system around people who would be categorised in discharge terms as maybe being on pathway 0. So needing some support to go home, but not needing a level of input from maybe local authority and healthcare services. And we put that to the voluntary and community sector people who came to join us at that invitation. And we asked them for their shared solution. So we said that our aim was to improve the patient experience and outcomes. This was our problem in the shared data that we shared with them, and obviously we wanted to reduce the pressure on our health services and our local authority services as well. But one of the key messages was that we almost sort of wanted to maybe apologise for the way we'd worked previously in sort of the local voluntary and community sectors being a part of the offer, but not really being embedded as part of that community offer. And really, part of that invitation was to say, how can you help us, and what would your shared solutions be? So that was the start of the conversation. Next slide, please. And the other thing that we did, and part of the conversation that we had, was that we wanted to change the conditions. We wanted to create the conditions for that group of people who then stayed with us so some people sort of left and said, actually, this isn't our area of work. We'll leave it to others who are interested. So we were left with a smaller group, which we then created a sort of some form around, and they became our local discharge collaborative. And what we did in terms of being able to convene and facilitate that was create the conditions whereby we changed our commissioning approach. So some of the feedback was that we'd had maybe some quite restrictive ways of working with them in the past. So we would have things like mini tenders and procurements for relatively small amounts of money, putting some bureaucracy in the way of what the voluntary sector could do in terms of their innovation. And as small voluntary and community sector organisations, putting those sorts of things in the way is actually really resource intensive for them. So we said that we wouldn't work in that way. That was our commitment. And we would put collaboration where there had been competition, and actually be very transparent about the amount of money we had. We had some money from our local discharge fund. This is the amount of money. This is what we already spend. What's your solutions in terms of how you would spend that money if you could come up with some ideas for us? And that's really was key to changing those conditions to how we work together. Next slide, please. So our local assets and the organisations that sort of said, yes, we're interested, some of whom were already working with us, others were providing services, but not in a coordinated way. So would be interfacing with the hospital, but on quite an ad hoc basis and not in a managed way. So that list isn't exhaustive. There are other organisations who are working with us, but the main people were the British Red Cross, a local organisation called Whole Home from Hospital, the Alzheimer's Society, who said we could actually offer something quite bespoke and specific for patients and carers who have dementia, Age UK, who were very interested in putting together an offer around follow-up calls for people once they'd gone home, and carer support, which was really important. So as well as the obvious and important focus on the patient, that support for the carer in that transfer of care was often critical to why people got readmitted. So this was a patient and carer offer, and our local mind as well. So the different offer was, one of our issues was that the wards weren't familiar with all those organisations, and on a busy ward, you haven't got time to think, would this person benefit from a referral to a voluntary sector organisation? How would I do that? How quickly would they respond? So we knew that was an issue for the wards. The organisations themselves said they had capacity that wasn't utilised because they weren't getting those referrals in. So, and under agreement with the group, we said that a VCS discharge coordinator to be dedicated within the hospital discharge team, but being the link to those wider organisations, would be something that we'd want to spend the money on. Two people actually were seconded from the voluntary sector into the discharge team, and they now work with the wards, and they provide that advice, intervention, transfer of care and support to the VCS, and support the wards as well. So that was one of the ideas, and we've now got that in place. I can tell you a little bit about that as I go through the presentation. The other key thing was settling in calls following discharge, and again this happened on an ad hoc basis, but wasn't really systemised or a sort of standard part of that transfer of care offer. And it was something that all the organisations said they would support, and Age UK in particular, and the British Red Cross said that they actually had the infrastructure to be able to provide that. We were really interested in scaling that up locally because our reattends were quite significant, and that goes back to somebody maybe getting transferred out of hospital a little bit earlier because there's pressure on the front door. And then once home, actually things don't quite work out. Maybe there are issues around the transfer of the medication. Maybe whilst they didn't need a full package of support from social care, they still need some support at home. So that's where the settling in calls came in. And that's been really significant and really well received by our patients and carers as we start the sort of evaluation of this work going forward. Dementia advisors are provided by the Alzheimer's Society, so the VCS coordinator can signpost people appropriately. And we also have long-term conditions buddies. So these are people who will follow home people who've got particular issues around their long-term conditions and continue that continuity of care and support into the person's own home. And again, either helping them self-manage or putting them in touch with some of our local services, telehealth, telecare. And also all these services will step up to our statutory services if that need is there. So that's just a little bit of an overview of what the group came up with and what we put together. Next slide, please. So the collective improvement journey, I think I said earlier when we were, our previous approach to commissioning had been quite bureaucratic, and the other thing that we were very aware of when we started working in this way with our local VCS was we didn't want to burden them with huge asks around data collection, but obviously we do want to evaluate this. We feel there's some real value for money aspects to it and real opportunities to inform investment going forward from our discharge fund, and absolutely fits with our local philosophy around much more early intervention and prevention and getting upstream in terms of what we need to do to support our patients and people to stay at home. So we do support them with some of the data that we need. The local partners understand the need for that, so are happy to provide that information. We have asked them to keep a check of the number of referrals, the source of referrals, the number of people that receive the calls, and then we're also tracking those readmissions, the increased utilisation of the VCS. As part of our discharge transformation programme overall, we're tracking the no criteria to reside numbers and length of stay. You can start to see there some of the early figures that are coming through. So these are the numbers of patients that are supported by the in-hospital VCS coordinators. We only started towards the middle of April, and you can see the numbers slowly increasing there. So the numbers of people that have been supported out of hospital in July was just over 400, and that number is increasing every month. We have, that's across about 1,100 beds across both our hospital sites, just for context. Thank you. Next slide. So what did we learn? Local data was key to sharing the awareness of the problem. We kind of held on to that as health and social care in the past, and why wouldn't we share it? There's no patient level data. It was really sharing the problem that we quite routinely shared amongst ourselves, but didn't necessarily share with wider partners. The learning was, why were we trying to do it all ourselves? With a very sort of formal NHS and local authority approach, and actually increasing our community and voluntary sector colleagues' understanding of the problem, created much wider solutions to what we could do. There's a real opportunity for this to scale up across our ICS. We are obviously sharing this with the other places, and they equally have elements of VCS input into their hospital discharge, but again, not necessarily systemised or scaled up in the way that we have, and there's an opportunity to do that. There's also an opportunity for us as part of the learning and evaluation, which, as I've said, is still in quite early stages, to keep on that improvement journey and to tweak things as we go along, and to adapt and scale up the community sector input. And I think one of the biggest learning for us, and as I say, I speak on behalf of the local discharge collaborative, is that why don't we think VCS first? It tended to be an afterthought. Where we'd commissioned it before, it had been a sort of an add-on to established pathways, and actually we would have done much more sooner if we'd have thought, what can the voluntary sector do first, and then build our pathways for more complex services on top of that. And I think that's learning that we've taken into some of our other areas of improvement as well, outside of the discharge work. So thank you. I hope that was helpful, and happy to take any questions.
Erica, thank you. We can say exactly why you were keen to share that example with us. It's fantastic. My takeaways before we just move into the panel session, my takeaways from that, and it would be great to see comments coming through as well. One of the things that strikes me, the most immediate thing, is behind every one of those numbers that you showed us on that last slide is a person who's benefited from this work, which is amazing. It's fantastic. What I also took away from that was an increased understanding of the issues within the wider sector, generating more potential solutions. And we know that none of us is as smart as all of us when we put our brains together, but having the opportunity to do that. And the key role of the ICB in creating the conditions you described beautifully. And if we think about the unique role of ICBs in terms of statutory duties, convening, commissioning, handling the purse strings, using data for insight and wisdom rather than just data for data's purpose. Beautiful. And local asset focus as well. So thank you, Erica. Lots of comments coming through in the chat. So I am going to put my colleagues in who are on chat box duty today. That is Kath, Lorna and Charlie. If I can put you on notice, I'm going to come to you in a very short minute and ask you to identify some themes and some questions coming through on the chat. I'd also like to invite colleagues on the call, if you have a burning question and you haven't, or maybe you have put it in the chat box as well, but you'd like the opportunity to ask our panel in person, please don't be shy. Please put your hand up and we'll come to you. But I'm going to take sort of chair's prerogative in the first instance, if I may, to our panel members, and just bring two sort of things together a little bit. If you look through the chat, you will see that one of the themes that each of you has talked about, which is using strategic improvement approaches on today's challenges, as well as the wider population health opportunities and improving population health. There are comments about actually how that generates a wider conversation, how that helps to engage. Whereas if we talk about healthcare improvement, there is a tendency for those boundaries, those protected boundaries and silos to emerge again. So there's something about that. And I'm conscious that I wish we could say that we'd done this deliberately, but we happen to have chanced upon the day to hold this collaborative masterclass on the same day as the DARSA report has been published, much heralded and lots trailed in the press. But what opportunities do you guys see arising from what comes from the DARSA report in terms of the policy context to support the issues that we've discussed today? Erica, I'm going to give you time to draw breath because I'm conscious that you've just finished your presentation. So David, if I come to you first, then Chris, and then we'll come to you, Erica. So if we could, David, any thoughts from you?
Yeah, I had lots of thoughts and some great comments in the chat box. And Erica, really enjoyed your story about whole work, because I think these practical examples just bring it to life. I mean, a couple of things. The first is, I think not just what's in our DARSA's report, but the response from Wes Street, and if those who heard him on the Today programme this morning, absolutely points quite a clear direction here. Really starting to invest in improvement and redesign at scale across the NHS, not just trying to invent new things and cascade them out from the centre, but learning from the best of what's working locally and creating a model for spread and adoption that gets that disseminated much more rapidly. I think that's really important. But also that shift left into a stronger focus on early intervention and prevention. And doing that, really, you can only do that if you do it fundamentally in liaison with place, with all of the primary care practitioners, with social care, but actually also with the VCSEF sector and with communities themselves. And Erica, that came across really clearly in your work. So I think there's a clear sense of direction there, which I think, I mean, fortunately happens to agree with my own personal views, which I'm delighted about. and is what we want to see NHS Impact supporting. And one practical example from me that I think complements what Eric has said, which is some of the work I've actually done with colleagues in Wigan over the last 7 or 8 years. They took the principles of what's called the Wigan Deal from local government, that real asset-based approach, what matters to you, what strengths we have in our community. And we thought through how do we apply that to health and to social care. And actually, pre-pandemic, we ran a development programme for 1,500 colleagues across the NHS, social care and the voluntary sector and general practice to give them that different mindset about how we work with individual patients and particularly how we work with communities. And it really broke down the barriers. And there are now sort of 4 big interrelated delivery programmes in Wigan, which are about improving population health and tackling inequalities, but really working with our priority wards, really, because that's often the places where we're seeing a lot of the avoidable demand coming through and much worse access to diagnostics and to planned treatments. Doing that through a really rigorous community engagement approach and investing in that. With a couple of points in the chat box about how we did that during COVID, really finding and engaging community leaders and community activists, really strong commitment to that in Wigan. Then a fundamental rethink of community-based services, not just old-style community nursing services, but community-based services, primary care, VCSEF, and others, are looking at really interesting innovative models like the Nooker South Central Foundation model in Alaska as one example, a long way away, closer to home. Great work going on in Rochdale, almost next door. So can we learn from both? And then, yes, working actually in this case with Newton Europe on a redesign of the urgent care pathways. I think those things come together. I think it would be a bit of a risk to draw a sort of dichotomy between population health improvement and service redesign and development. I think that they're on a spectrum and we need to work across that whole spectrum. And I think that's the direction of travel in terms of policy and politics as well, Steph.
Brilliant. Thank you, David. Chris, anything that you'd like to add to that?
Yes, if I may, Steph, thank you. The Darcy report is mainly about the NHS. You asked about how this discussion is relevant to Darcy. So social care and public health were actually not in the terms of reference. Didn't stop Darcy having to say some things about social care and public health, but it wasn't the main focus. I think more potential is in the work that's now started on the 10-year plan. And I was in a meeting yesterday where we got an update on the early work on the plan, and significantly, it's a 10-year plan for health, not a 10-year plan for the NHS. So by definition, these wider issues around population health and prevention are in scope for the 10-year plan, and I think that's where the focus should be. David quite rightly highlights the work in Wigan, the Wigan Deal, which I'm familiar with, and the King's Fund published a good report about the experience with the Wigan Deal 4 or 5 years ago now. I'd be significantly, I'd say, David, but you're closer to this than I am, the Wigan Deal emerged from local government leadership, from the elected members like Peter Smith and 1 or 2 others saying, look, in a period of austerity, we can't do more of the same. We can't just get through salami slicing our services. We need to be bolder and more radical, which led, and it wasn't perfectly designed from the beginning. They learned as they were doing this work, which led to the approach where council staff went out into their communities and they talked to local people with an open mind, and they listened to what mattered to local people, and then they co-designed what the response should be. So I think some echoes of what Erica was describing. And I emphasize it was local authority led because, can I be rude to some extent to NHS colleagues, I think local authorities have more experience, more understanding of how you do these things than many NHS organisations do. There are some notable exceptions to that generalisation. I think that points to the importance of the ICPs, the wider partnerships within ICSs, and particularly how that plays out at the place level, as in the excellent example from Erica and the example I referenced very briefly in Wakefield in West Yorkshire, and there are many of those now, because their place is where most people identify. I don't think people on the high street say, I live in Humber and North Yorkshire. They say, I live in Hull or a suburb of Hull. I hope I'm right in saying that, Erica. You can keep me honest on this. And it's also what our local authorities and our voluntary sector organisations and many of our NHS organisations identify with. So ICPs place partnerships as a key vehicle for doing this work. And I think here I go back to my point. It's less well described, less well understood what the improvement methods and approaches need to be around these much more wicked problems that places are confronting. Erica's given one great example. There are many others besides. So I make a plea really for, can we sort of try and capture what's happening, add to our stock of knowledge, share that in a very practical way. There's no harm in reinventing wheels all over the place, but we can facilitate and accelerate that if we're much better at evaluation and recording what's happening, successes as well as failures.
Chris, thank you. Erica, would you like to come in there? And if I can invite colleagues to just in the chat box as well, identify what you're doing and what you're seeing working well at place level. Tell us what's working. Share that information. Erica, over to you.
Thank you. Absolutely agree with everything that David and Chris have outlined. I think what we've got ahead of us, particularly with the Darcy report and recommendations, we know that we're working in a very restrictive environment in terms of the finances, and but I think that sometimes forces the innovation. So my example, I didn't actually say it in the presentation, but we were only looking at 160k that we had to play with. But actually already from the early evaluation and the feedback that we're getting both from patients and carers and the organisations that have partnered with us on this, is that the sort of those small improvements actually in terms of what they'll realise in benefits and outcomes will have an impact in terms of resources and capacity within our system further down the line. So I mean it's an old sort of phrase that I remember from some early days in improvement, that if you you look after the quality and outcomes, then the money will follow, and I think that that still stands, and we sometimes get too hung up on what we haven't got, and actually investing in the right ways and in the early intervention and prevention does realise that for us later down the line. And I think that's that's going to have to be how we work and accelerate that way of working.
Erica, thank you. I'm going to turn to my colleagues, Kath, Lorna, Charlie, who are keeping an eye on the chat box. And would someone like to, Kath, I think, probably, step forward and let us know what we're seeing in the chat? Any questions or any themes that we'd like to invite our panel to respond to?
Thanks, Steph. So lots of people really welcoming what they've heard from our three speakers. A number of questions, and I'm not sure we'll be able to get through them all. But just going back to Rosemary Smith, I think a question for David. Would you be planning to embed and nurture peer leadership roles within the improvement plan?
Yeah, great question. So I'm going to address that in a number of different ways. The answer is absolutely yes. I think it's something that's quite underdeveloped in lots of parts of the NHS at the moment. It's been interesting having joined the Mental Health LD and Autism Trust. I see it a lot more than I would have done when I was working in the acute sector as a non-exec or indeed as a chief exec. And we have some great peer facilitators, peer support workers, and also we've actually trained a lot of people who've used our services in improvement method to join improvement teams as experts by experience. And the value back from that is immense. It's one of the reasons why we now take the step to the National Improvement Board to invite experts with experience onto the board itself. So we've got that voice in the room all of the time. I worry slightly about it sometimes because I think in the current financial climate, people might think, well, here's a more cost-effective way. We can replace a member of staff with somebody who's a peer support worker. And that kind of misses the point. Interestingly, I was discussing exactly this when I visited our wards in Blackburn earlier this week and actually talking to a couple of our service users on the ward itself. And they were talking about how they'll have a very different conversation with somebody who has had the same problem, been through the same set of circumstances that they have. And they were positive and complimentary about the support we're getting from our professional colleagues. But actually that support from peer workers and peer facilitators was really, really critical in their recovery. So yes, it's definitely something I personally would like to champion. I'd like to see NHS Impact championing more as well.
Thanks, David. Sorry, I couldn't unmute then. So several other, like I say, lots of questions in the chat. I think a great one from Claire Hamill. She would be interested to hear views on what needs to change in NHSE and ICBs to support and facilitate a continuous improvement approach in systems and organisations. What's getting in the way of us doing it already? Who would like to take that one?
Chris, would you like to take that one first? Is that all right?
Yeah, no, happy to have a go at that. So, I mean, I think Amanda and her senior colleagues, from my contact with them, are very supportive of making improvement much more mainstream within the NHS, which is why they've appointed David and National Improvement Board to provide the momentum and the leadership around NHS Impact. And I think that's good. And David, you referenced, I think there's a report about to appear soon on the first priorities and the initial work that you and colleagues have been doing. So I think the door is open there. Obviously, if you're in those national roles, there are always competing priorities and different approaches that your colleagues will bring to bear around in a big complex health and care system such as the one we're all associated with. What is the best way of reform? What's the best way of improvement? And old habits will die hard. You know, let's be honest about this. Performance management and hierarchical relationships coexist with more improvement-led approaches. I think that's something that ICSs and ICBs can help to mediate, because when they work at their best, in my experience, they do provide an umbrella to protect people actually delivering services in organizations, in places, in neighborhoods from some of the contradictory demands being placed on them from above. So I think that's a strong argument for having the systems in place and having experienced people leading ICSs and ICBs and able to, if you like, push back when they're getting demands that aren't going to be supportive of some of the work that we've been discussing today. But I go back to where I started. The ambition here is huge, and that's great. I'm not being critical of the ambition. Doing health and care improvement at scale across a population as large as the one in England has never been done before. So if we bring it off, we should be very proud of that. And even if we only bring it off in a small number of systems, we should be proud of that. But it does require political leadership, not just NHSE leadership. So I've heard Wes Streeting speak on a few occasions about, I think he said something like, for every problem or challenge in the NHS, there is a solution somewhere else in the NHS, and we need to be much better at connecting the two. And I think he's right in that regard, but he hasn't said what his plan is around how to make those connections more clearly. It is about the peer-to-peer. It is about how you create time and space for people to learn with each other, from each other. So, we need learning and improvement communities, not just in individual systems, but in regions. And that's what North Eastern Yorkshire have done, I think, better than other regions. They created much more collaboration between the 4 systems there. Erica, you'll have a view on this, but that was my impression in the work I did. And the systems genuinely spent time supporting each other, working with each other, collaborating, trying to make use of all the expertise that exists. And I'd love to think that would become common practice across the rest of England sooner rather than later.
Thanks, Chris. Yes, by all means.
Briefly, so I agree with everything Chris has said, and I do spend quite a bit of time with NHS England colleagues. It's been a delight over the last year. And I actually think there is a really genuine commitment that they want to put improvement at the heart of the NHS, and they also want to transform the way NHS England itself works and the way ICBs work. That is hard to do. All of us who've tried to do it at provider level or place level know how hard it is. And when you're in a big national organisation and you've got all the political pressures, there's an added layer of complexity to that. And I think they need help and support. And I think it would be great if colleagues on this call and NHS organisations would say to NHS England, we've got some great examples of how you do an improvement-led transformation. Come and see it, come and learn from it, we'll help. And then when I talk about board development, that's not just for provider boards or place partnership boards. That needs to be for ICB boards and for the NHS England board as well, if we're really going to have that leadership from the top. Final thing I would say though is it'll be great if we get that, but the NHS is a really, really big place, and we can get a lot of improvement and transformation to happen, even if ICB and NHSE haven't quite got there yet on their own improvement journey. We can do these things in parallel. But it's a great question that people have raised.
Thanks, David. And if I'll come back to you, I'm keen to ask Erica from her perspective, what would make the difference? What does make the difference? What would help? What could really amplify the approach? But David, if I could come back to you first. You mentioned leadership development, but you also mentioned earlier learning networks, collaboratives, and how they could play into this. I'm just wondering if there's something there that we just need to get people sighted on and looking out for.
Yeah, absolutely. So Chris has mentioned it a few times, that peer-to-peer learning. I think it is incredibly powerful, more powerful, frankly, than sending out best practice guides or issuing instructions from above. Learning from a trusted peer and actually being able to go and see how people have done it on the ground. I'm already thinking, Eric, can we get a team from my trust to go and look at the whole experience and what you've done? I think that is really powerful and works really well. And so as part of our approach to creating the conditions to spread and adoption, we want to promote these kind of models, learning and improvement networks that are long-standing, that have a bit of infrastructure to support them, that have really good buy-in from the organisations, working on an all-share, all-learn basis. So everybody comes with curiosity, wanting to know what others are doing, and everybody will have something proud that they can share with other people. And the intention is that for both elective flow and emergency flow initially, that those networks will be set up through each of the regions. So each of the 7 regions will have separate networks, bringing trusts and other partners together. In time, I'd like to see it take that further and probably develop something that looks more like a large-scale improvement collaborative, bringing a much broader group together. And again, when I was in my own trust talking to colleagues on the ward just earlier this week, they were really excited at the idea of bringing together some of our ward staff with social care colleagues, with housing colleagues, people from the community, to say, what would an improved system for discharge of mental health patients, particularly those who are homeless or with housing challenges, what would that look like? So I think, Steph, we want that learning, all-share, all-learn approach at scale, and NHS Impact can try and do that. And that's almost to send the signal that learning from each other is so powerful and inspiring if we can just create the time to do it.
Brilliant, thanks, David. Erica, from your perspective, what helps?
Support to take some risks, I think, definitely. Clinical leadership at the forefront of what you want to do. So I suppose the equivalent with the example I gave was the voluntary sector. So putting them in that space, in that leadership space, and standing back. But in other areas where we've had some successes, it's been around clinical leadership being at the forefront and being the voice of, the patient and carer. So definitely support to take some risk where you've got some examples of maybe small scale impacts, but you can see the benefits of being able to scale that up. Yeah, and holding your nerve when you know something's working. Sometimes it can be really easy to give up because you get pressures from other areas, to deliver on things. But hold your nerve if you know that you've really got something good and it's gonna really change things. Sometimes it takes a bit of time, but then when it does realise those benefits benefits. Everybody wants to know about it. So yeah, that would be those would be my thoughts.
Brilliant. We might have to get T-shirts printed with "Hold Your Nerve," I think. Brilliant. Thank you so much. Kath, can we come back to you? What else are you saying in the chat box?
So there's a lovely question from Stuart Clough, who Aqua know well. And I wondered actually if Stuart wanted to ask it himself. It's around clinical engagement.
Stuart, can you come off mute? Brilliant.
Sorry, I was struggling a bit like you were there, Kath. Yeah, so I think what made me think, David, when you were talking about NHS impacts is obviously it's well timed and it's a great thing, and obviously the way that the NHS and other organisations need to move forward. I think what I was thinking about is how do we socialise that across the entire, in my situation, the entire organisation, because sometimes it's a little difficult engaging clinical teams because they don't see things that perhaps I see in my role in the organisation, and sometimes they don't see the value as much as maybe what I do as well, given the nature of the clinical pressures, of course, because obviously patient care comes first, but how do we help them see the bigger picture and get them engaged in doing things in a different way?
So nice to see you again, Stuart, and thank you as ever for the tricky question. Always nice to get those from you. I mean, that's exactly the job of leaders, I think, what you've described. And for me, it's not so much about promoting and socialising NHS impact. It's almost the other way around. It's how NHS impact can help and encourage organisations to promote and socialise improving the work that we do every day. And when you say it's the more concerned with patient care, this is about patient care. This is about the care that we improve for our patients every single day. That has to be the message. And my experience with frontline colleagues is when you start to describe it initially, it kind of sounds a bit like management speak. It sounds a bit alien, not sure how that relates to me. But if you get the chance to give people the chance to apply it hands-on and they start to see the improvements, they become huge enthusiasts. And I think actually giving staff the tools and the support and the encouragement and the time to improve the care that they deliver every day is one of the most motivating and inspiring things that we can do for people. And I saw it was in the chat box, one of my LSCFT colleagues is clearly on the call, that certainly within Lancashire South Cumbria Foundation Trust, the trust have been at this for about 4 years now, a really rigorous approach to training, so everybody gets an introduction to improvement at induction, but then is expected to be engaged in some improvement projects, some improvement activity early on. We've trained a lot of frontline leaders in how they support and encourage the use of improvement method. We have a bottom-up programme called Empower to help people, support people working on their own improvement projects, as long as our big, large-scale transformation programmes. And what I see as everywhere I go, and I visit a couple of places every month, everywhere I go around the trust, I'm seeing those examples of improvement. So on the 6 wards in Blackburn earlier this week, they were showing me their own charts around reducing restrictive practices on the wards, about how they've reduced stumbles and trips and falls for people on our older adults ward, people often with dementia, how they were using an improved approach to increase the range of activities so that people didn't get bored, they had purposeful occupation on the ward. And they were really interested in the idea of us organising an improvement event to bring together ward-based staff with social care colleagues and housing to help get some of those people who are ready for discharge, out to work they needed to be in the community. And we talked about all of that. I didn't mention NHS impact, and we didn't necessarily use improvement speak, but that's what they were doing, and they were using a robust method to do it. So I think it's just about, that's what, when I'm talking about it being embedded, this is how we do it. It's back to Yon Shopping, the 2 jobs, to do our job and to improve our job every single day.
Thanks,
Steph, can I come in briefly to add? Nobody's really picked up on the point about where provider collaboratives fit into the discussion we're having. And my experience is that they're not the be-all and the end-all, but when it comes to engaging clinicians, if you have a well-established provider collaborative, most of the work that collaborative does is done by clinicians who come together from different organizations around high priority areas for improvement, which might be to do with some very specialized services, or it might be to do with elective recovery, or it might be to do with emergency flow, or it could be much more around some of the vertical integration opportunities. And a provider collaborative really can't succeed if it's just a group of executives from the top team sitting around the table together. West Yorkshire Association of Acute Trusts fundamentally has been on a journey where it's facilitated, enabled, freed up time from hundreds of clinicians across West Yorkshire around particular priority themes and clinical services, and supported them with data, with managerial input, and with endorsement from the top leaders to go forth and deliver improvement in ways that aren't just about individual services or individual trusts, but are much more doing it at scale, where that is the only way of achieving that improvement, which increasingly is going to be the case in other systems too. So I think bringing provider collaboratives much more into the center of this debate is one way of answering Stuart's question.
Thank you. And can I just sort of pick up on one thing, and Eric, I'm keen to hear your perspective on this as well. To what degree does that require our clinical leaders to not just be cognizant of, you know, improvement approaches, but it's that system leadership aspect as well that you spoke about, Chris, that is really important, because we equip our clinical leaders to undertake their roles, to get involved in improvement work, but actually making some of the brave decisions that you were describing earlier around fragile services and redesigning pathways when it might impact on my particular clinical practice. That's a different type of leadership that is required of them. So to what degree did you see in the examples that you studied, see that taking effect? And Erica, to what degree was that important, particularly in the discharge example, but in others that you're cognizant of in Hull? So Chris, if I come to you first.
Sorry, Steph, I thought that was a question you were going to put to Erica. So
well, both of you really. So Erica, do you want to go first, and then I'll come back to you, Chris? Thanks, Chris.
Yeah, that's fine, no problem. Yeah, I'll use actually another example, which is our frailty services, which have been running now for 6 years, but really was one of the areas that we did take a bit of a risk on, actually, and we put clinical leadership at the forefront of that in terms of bringing some of our community geriatricians out of the hospital setting to work in the community. Now, I know that's not necessarily a great innovation, and that happens a lot around the country, and I think it's definitely where those clinicians with that particular area of expertise need to work. But we gave them the sort of opportunity to look at what a model of early intervention and prevention and anticipatory care would look like, and we were being steered down to more of an urgent care approach, and we sort of again held our nerve and said, no, we think that if we just sort of use this as an urgent care service, we'll just create another urgent care pathway. What we need to do is do much more of the upstream early intervention, prevention, anticipatory care, proactive, comprehensive geriatric assessment. And that's really taken off. You know, we can demonstrate in Hull now that we've got data which the clinicians are already sharing in their peer groups and across networks and within our ICS on how we've achieved a 20% reduction in admissions of older people who've had that comprehensive assessment. And so what we've done in terms of scaling that up, it is about getting behind them and doing some of the sort of, putting some structure to their ideas. But generally speaking, the clinicians I've worked with think with an improvement methodology, but they don't have the time to put the program to it. So that's where myself and colleagues would come in to support that. And now, as Chris alluded to, that the concept of a collaborative across a wider geography, we're using our community collaborative across Humber and North Yorkshire to lift that work up, and we've created what we've called a centre of excellence for frailty that those clinicians are leading. They've created a clinical network across our wider geography and come up with 10 principles for frailty, which are now being adopted on a bigger scale. So the delivery models in each of our geographical places will be slightly different, as they should be for the population needs. But those principles of how to manage frailty in the community have been signed up by a clinical network across a much bigger geography. So I think that collaborative approach definitely is supportive of taking clinical leadership forward on a bigger scale.
Thanks, Erica.
Thank you.
So
Chris,
if I come back in step briefly, I've got two thoughts on this. One is we should not forget our history, by which I mean it's a big picture point, really. It goes well beyond the discussion today, but the transformation of mental health services in the last 50 odd years. When I started my career working with and for the NHS, there were still very large asylums caring for hundreds, if not thousands, of people with a variety of mental health problems. There was a huge transformation, difficult as it was, to move much more towards a model of community-based mental health care. And I think there are big lessons from that, if we can remember them and capture them, on the wider transformation. I suspect we're going to hear much more about from Keir Starmer and Wes Streeting. It isn't an exact parallel, but if they're saying we need to, as it were, stabilize or shrink the role of acute hospitals so we can invest more in primary care, general practice, community services, social care, then I think there are some learnings there that we need to capture and act on. We didn't call that an improvement program. We didn't call it a transformation program, but effectively it's the biggest one there's ever been in the history of the NHS. Briefly, the second thing I was going to say, adding to Erica's contribution, I think there are some fascinating examples in different parts of the country of hospital-based specialists in acute services who've themselves been innovative in saying our future lies both in the community and in hospital. We think if we work alongside general practices and community teams, a lot of the routine work can be much better done. This, if you like, is an example of clinically integrated care by the paediatricians sitting alongside the general practice teams and doing co-consultation in community settings for parents and children through early intervention and to prevent the referral on to hospital. And there are half a dozen other examples that I'm quite familiar with now around older people services as well as children, and in some of the mainstream ologies within acute services. Again, if that's what Wes Streeting and Keir Starmer are saying we need more of, then let's really capitalize on the fact that this is already happening. We've got clinical leaders having taken the lead, not always popular in the systems in which they operate because they're bucking the trend, but they're positive deviants, if you want to use that language. And we need lots more positive deviants in the NHS. And I think having clinical leaders in that role would make a lot of sense.
Yes, thank you. Kath, if we can just do one last question, I think, from the chat, then we'll be at almost time. I think it's been a fantastic conversation. I'm keen not to stop it because we could listen to you guys all day. We really, really could. And there's some fantastic messages coming through in the chat. So, Kath, one last message.
Really struggling with the unmute button today. So there is a great question from Adam. Adam Drage. I don't know if I've said that right. Adam, your question around working with the VCSE, would you like to pose that to the panel? And then Steph, Joe Knight has a hand up as well, so I don't know if we can squeeze another one in after Adam has asked his question.
In order to squeeze another one in, and I'm keen we do that, can I just say there is a link through to an evaluation form in your chat box. So if you're on the call, please do take time to give us your feedback. So Adam first, and then we'll go to Joe.
Can you hear me?
Yes, we can.
Yes.
Yeah, so what I said is this. So I work in mental health services in transformation, and obviously we really want to work more systemically with the voluntary sector as part of our core model. It's crucial. But I think there are two real challenges that we experience. One of them is around the lack of data flow in mental health. It's to our mental health data set, but it would be the same anywhere. And obviously the voluntary sector, by nature of what they're doing, you can't fit their data into the NHS boxes. But what it means is it's very difficult to then evidence the activity alongside the agreed subcommission contracts. And that actually becomes a really, really big block to moving on from short-term pilots to actual kind of embedding within core NHS services. So that's one of the challenges. The other one is, it's probably linked into that, is we struggle to move beyond sort of short-term contracts with the voluntary sector organisations, which means, you know, they can't sustainably grow and workforce plan, etc. So everything feels like nice short-term projects, and we struggle to actually scale it up. So any thoughts on these challenges?
Would you like me to come in on
Thank
that,
you,
Steph?
Adam. Yeah, can we very briefly? If I
Very
ask
briefly. Yeah, I'm happy to be contacted, Adam. I've put my email in the chat, but yeah, I think we have to really support them. That they don't have the resources and infrastructure to, as you say, create that data set. So it is about being much more flexible around commissioning, and what we made a conscious decision within our local authority and the ICB commissioning that we would move away from those more rigid contracting procurement type approaches. And yeah, I think you need to make a definite decision to do that. And yeah, short term's not good, and whilst it's voluntary sector, it's not, you know, you still have to pay for it, and we should factor that in. So yeah, but happy to be contacted if we're running out of time and tell you more about what we've done in Hull.
Erica, thank you, and that's a very generous offer. Adam, I do hope you take Erica up on that. Chris, anything from you briefly on that question? No? David, anything to add?
Very briefly, there are some great call coaching schemes around, because I think often colleagues within the voluntary sector really struggle with all the bamboozled by the huge hierarchy of NHS and Commission and all the rest of it. And equally, NHS leaders don't really understand what it's like to work in a small voluntary organisation. Now, there's some great schemes where we bring voluntary sector and statutory sector colleagues together to coach each other, and we need to do a bit more of that, as well as the kind of just the commissioning framework, I think.
Brilliant, thank you. Joe Knight, Joe's got your hand up. Joe, would you like to just come off mute and ask your question as well before we finish? Thank you.
Thanks, Steph. So I'm a QI facilitator with an improvement and redesign team, and obviously we have a struggle in terms of the use of our time as kind of key individuals around improvement. One, around striking that balance around our time for delivery in terms of leading those improvement programs and kind of investing now in that improvement, but also investing in the future and building that capacity and capability with others, and kind of that social movement, as you spoke about, David, and that kind of comes and kind of building kind of that culture of continuous improvement. And just wondered whether there was a view around striking the right balance on that, and where to invest that time within the teams that we have. We have a finite resource. Where is it kind of best placed? What kind of split would be advocated? And also interested in terms of those who are on the call, who are part of trusts with kind of QI teams or transformation teams, and what split that they're currently running at in terms of those two areas.
If we can ask colleagues on the call to put that in the chat box, Joe, and we'll get that from everybody on the call who's got a view. But to our panel, would anybody would like to respond to Joe's question?
You want me to jump in very quickly? Big question, Joe. We've got about a minute left, I think. I don't think there's an algorithm. I don't think you can just feed it in and it'll give you the answers to what the balance are. Again, it's a leadership challenge. It's managing that polarity, and you've described it really, really well, I think. I mean, there is some evidence around for how many thousand staff you've got, the sort of scale of central function and facilities that you need. I'm sure you've seen that kind of dosing formula that Kaiser Permanente developed and IHI popularised. So I think that's a good start. And it's a balancing act. And initially, I think, if you're at the start of your improvement journey, a lot of folks will go on hands-on support from the QA team. But I would say I would move really quickly to try to develop skilled improvement leaders within the organisation who are almost associates, adjuncts of that improvement team who are leading the hands-on improvement work, so that the improvement team can kind of concentrate on the next horizon, and probably supporting some of the bigger, more fundamental transformation programs, the big leaps of transformation, not just the small steps of continuous improvement, and move into more of a coaching and facilitation and support role. And I don't know where, you might tell me your work for my trust, I don't know, but I don't know where you're up to on that journey. The answer will be slightly different for everybody. And it's if we PDSA it, we don't get it right first time. We just keep working at it. It's the classic building the plane while we're flying it challenge. It's hard and it's frustrating, but it's great fun when you get it right as well, isn't it? Brilliant.
Thank you. What a brilliant question to end with. Really inspirational stuff. Thanks, Joe, for asking that. I am obviously a rubbish chair because we're slightly over, but I think that's testament to the fantastic conversations that we've had today and the brilliant questions that we've had for our panel members as well. Lots of fantastic information in the chat. Please do spend a couple of minutes completing our evaluation. And while you do that, may I thank, on behalf of everybody here, our panel members. Thank you so much for spending time with us. Thank you for sharing your thoughts with us, your insights, and bringing us back to what's really, really important from different perspectives. Really, it's been a fantastic session. Thank you to everybody who's joined us. Thank you for your energy. Thank you for your thoughts. Thank you for your questions. Thank you for being with us. Please evaluate us. We'll see you at the next masterclass. And as a final thank you, can I say thanks to the team, the collaborative team, who behind the scenes make these things work so well and make it easy for us to spend time listening to some great sessions and contributing to some great conversations. Thank you, everybody. Have a great rest of the day, and we'll hopefully see you at the next masterclass in October. Thank you. Take care. Bye-bye.